Greetings, my ladies. I just love giving you the royal treatment when it comes to ensuring that you receive the menopause education you deserve. I think you've already seen that menopausal women are not receiving the royal treatment by medical practitioners. Heck, they aren't even receiving civil treatment. Well, I'm Menopause Taylor, and while I am a gynecologist, I do not give you the same neglectful treatment that you encounter with most physicians. One of the things I offer, which is unique, is an actual complete education on menopause. If you start with video number 1 and watch all my videos in order, you will receive the royal treatment and know everything you need to know in order to successfully manage your menopause your way. Royal treatment is meant to give you the whole truth and the whole story. But you can only benefit from it if you learn the material in an orderly manner. So, I present everything in units. And this is the unit on epithelial ovarian cancer. In my book, all of chapter 32 is on epithelial ovarian cancer. But we'll be addressing treatment today. And in the book, I give you only basic treatment on treatment. Here, in this video, I'm going to give you royal treatment. In the videos preceding this one, you've learned that epithelial ovarian cancer is a disease of torment for women. This is because we have no way of diagnosing it in its early stages. As a result, 80% of cases are stage 3 or 4 at the time of diagnosis. And that is a real predicament because stage at diagnosis is what dictates treatment. So let's delve into treatment of epithelial ovarian cancer. Way back in the unit on cancer in general, you learned that all cancers begin as one single cell that becomes abnormal and then grows rapidly and uncontrollably. The kind of cancer that develops depends on the kind of cell that becomes abnormal and then grows rapidly and uncontrollably. The designation of a cancer as mildly aggressive, moderately aggressive, or very aggressive depends on the personality of the cell that becomes cancerous in the first place. The grading of epithelial ovarian cancer is what reflects the degree of aggression. Here's the chart we created in the last video depicting this. Well, now we're ready to discuss treatment of epithelial ovarian cancer. And the degree of aggression is a major factor in choosing the proper treatment. The other major determinant of treatment is stage. Stage refers to how far the cancer has spread. Treatment for a localized cancer will typically differ greatly from treatment for a metastatic cancer. For every cancer, there is a staging system. Here's the one I taught you for epithelial ovarian cancer in the last video. So treatment of any cancer is always determined and governed by its grade and its stage. But back up a bit. We use the word treatment so matter-of-factly. How can treatment mean the same thing for a mildly aggressive stage 1 cancer and a very aggressive stage 4 cancer? It can't. So it's always good to ask, what is the goal of treatment? Or in a more tongue-tied terminology, what is meant by the word treatment? Is it treatment to cure the cancer completely? Or is it treatment meant to stop the advancement of the cancer? Is it treatment meant to result in improvement of the cancer? Could it be treatment meant to protect other organs from involvement with the cancer? Perhaps it's treatment meant to prevent the development of recurrent cancer. Sometimes it's even treatment meant for deferment of death from the cancer. As you can see, there is a wide range of what is meant by the word treatment. And it is very common for doctors and patients to differ in their understanding and expectation of what is meant by the word treatment. In all the other units on cancer that I've presented, you've seen that there are three broad categories of cancer treatment. They include surgery, chemotherapy, and radiation therapy. Which of the three do you suppose is or are most useful in the treatment of epithelial ovarian cancer, and which are not? How about a quiz question on this? Which of the following treatments is not beneficial in the treatment of epithelial ovarian cancer? A, radiation therapy. B, surgery. C, chemotherapy. D, surgery followed by chemotherapy. E, chemotherapy followed by surgery. F, localized chemotherapy. G, palliative therapy. H, A, and F above. I, B, and F above. I don't think many people stop to think about which kinds of treatments are meant for which kinds of cancers. Of course, treatment does vary by grade and stage, but generally speaking, certain treatments are meant for certain cancers. So what's your guess? Well, here's the quiz question again with the answer in bold. That's right. While radiation therapy is meant as a treatment for many other kinds of cancer, it is not meant as a treatment for epithelial ovarian cancer. Can you think of a reason why this is the case? It's because radiation works best for cancers that are fairly localized. But with that darn saran wrap draping over all your abdominal and pelvic organs, there is nothing localized about epithelial ovarian cancer. So with that as your foundation, let's talk about the options that are meant as treatment for epithelial ovarian cancer. And let's address what is meant by treatment. I'd like to organize the material by category before designating treatment by stage. So I'll explain what's entailed with each of the following: surgery, chemotherapy, surgery followed by chemotherapy, chemotherapy followed by surgery, localized chemotherapy, clinical trials, and palliative therapy. So let's dive into this. Surgery is first. Back in video number 437, you learned that the actual diagnosis of epithelial ovarian cancer requires surgery. So the surgery is both diagnostic and therapeutic. So I'll separate the two goals of diagnosis and treatment, and that way you can see the role that surgery plays for each one of them. Okay, so diagnostic surgery is first. For purposes of diagnosis, there are very specific procedures that a surgeon must do to confirm and rank an epithelial ovarian cancer. These procedures fall into different categories in terms of what the procedure entails. The categories of procedures include visual inspection, cytology, biopsies, organ removal, and lymph node removal. And I'll very briefly explain each one so that you have an idea of what the diagnostic surgical procedure entails. The first and most self-explanatory is visual inspection. Your surgeon carefully inspects all the surfaces of your abdominal and pelvic organs with his or her naked eye. The goal is to note which ones appear to be invaded by cancer. That's all. The second procedure is cytology. Cytology is the medical word for cells. So cytology is a means of collecting cells that may contain cancer. But collecting cells by cytology does not involve a biopsy. Instead, it involves nothing more than collecting the cells that are floating around in your abdomen or pelvis. So we collect them by performing abdominal and pelvic washings. Abdominal and pelvic washings are a means of collecting free-floating cells from your abdomen and pelvis for cytologic examination. So here's how we perform abdominal and pelvic washings. We take a bucket of sterile water and we dump the whole thing into your belly, and then we jiggle you around a bit, and after jiggling, we suction all the fluid and send the entire bucket of it back to pathology for the lab to do a cytologic examination under the microscope. That's all. The third procedure is biopsies. Biopsies are tissue samples that are sent for pathological examination under the microscope. And biopsy sites fall into two categories: directed and random. In video number 416 on the anatomy of your ovaries, I taught you that your ovaries have an outer skin-like covering called serosa, and it looks like saran wrap. And I told you that it extends beyond your ovaries and covers all the surfaces of all the organs in your pelvis. So here's a model of your pelvis, and this saran wrap covers everything. And remember, the very kind of epithelial ovarian cancer that is the topic of this entire unit is serosal epithelial ovarian cancer. Well, that means anything covered by this serosal covering has to be biopsied. Directed biopsies are mandatory. Every surgeon operating on a woman with possible epithelial ovarian cancer must biopsy the saran wrap covering your bladder, the saran wrap covering the side walls of your pelvis, either side, the saran wrap covering the area here behind your uterus, the area covering either side of your uterus, and the undersurface of your diaphragm. Now, in contrast to these mandatory directed biopsies, random biopsies are biopsies in areas other than the ones I just designated. They're just the areas that just so happen to look suspicious. All biopsies go to the pathology lab for microscopic evaluation, and that's how you get a tissue diagnosis. The fourth procedure is organ removal. This refers to the organs that the surgeon takes out completely. They include your uterus and cervix, your fallopian tubes, your ovaries, your appendix, and your omentum. The word omentum is probably new to you. It's merely an apron that hangs over all of your abdominal and pelvic organs at the front of your belly. And it consists of saran wrap and fat. That's all. Just saran wrap that's really kind of fatty. And all these organs go to the pathology lab for microscopic evaluation. The fifth and last procedure is lymph node removal. Your surgeon removes the lymph nodes in your pelvis and along your aorta, and they go to the lab for microscopic evaluation by the pathologist also. Now, all of that surgery is required just to make an accurate diagnosis. Do you see why there is no screening test that is worthy for epithelial ovarian cancer? Screening tests give us false alarms. Can you imagine having all this surgery just to discover that is all a false alarm? It happens. This is why epithelial ovarian cancer is so horrible. Now, the results of the microscopic examinations of all these fluids and tissues are what determine the actual diagnosis in terms of grade and stage. But the good thing is that the surgical procedures I've just described for purposes of diagnosis also serve as a means of partial treatment. So now let's shift our focus to the aspects of the surgery that serve the purpose of treatment. The goal of surgery is to remove as much of the cancer as possible. Sometimes the diagnostic surgical procedures are enough, all by themselves, but sometimes they aren't. For instance, if your surgeon discovers that your intestinal wall is invaded by cancer, it may require removal of part of your intestine. And the same goes for any other organ that is invaded by the cancer. So the exact surgical procedure that functions as a means of treatment may differ greatly from the one that functions as a means of diagnosis. The two are done at the same time, if possible. But since the extent of the surgery done as a means of treatment varies from case to case, we have one label for all surgical treatment, regardless of their differences. We call them all a primary debulking surgery. Some people use the word cytoreductive in place of the word debulking, but they both mean the same thing. Primary debulking surgery, or primary cytoreductive surgery, means removal of as much of the cancer as possible. And sometimes it's just not possible to remove all the cancer. This can depend on the extent of the cancer or the frailty of the patient or the quantity of blood loss. There are even categories for how much cancer remains after the surgery. A complete resection means there is no cancer remaining. Optimal cytoreduction means that there is 10 millimeters or less cancer remaining. Suboptimal cytoreduction means that there is more than 10 millimeters of cancer remaining. So the terms primary debulking surgery and primary cytoreductive surgery designate the goal of the surgery rather than the specific procedure. What really matters is how much cancer remains after the surgery. Okay, that's a lot about surgery, but surgery is the most important part of treatment because it paves the way for everything that follows. Our second category of treatment is chemotherapy. You're already familiar with the term chemotherapy. However, we tend to use it as if it means only one thing, but it doesn't mean only one thing. Chemotherapy differs in terms of timing, route, and drugs. And I'll tell you a bit about each of these. Timing refers to whether you have chemotherapy after the surgery or before the surgery. And of course, we have medical terms for each. The most common order is surgery first and chemotherapy second. The medical term for surgery first and chemotherapy second is adjuvant chemotherapy. So adjuvant chemotherapy, abbreviated AC, is surgery first and chemotherapy second. The word adjuvant means helper. So adjuvant chemotherapy after the surgery helps to destroy any cancer that was left behind. So you can see why it is so important to remove as much cancer as possible with the surgery. The less cancer left behind, the better the chemotherapy will work. So whenever possible, surgery is first and chemotherapy is second. The alternative to adjuvant chemotherapy is to reverse the order of the surgery and the chemotherapy. Chemotherapy first and surgery second. This is called neoadjuvant neoadjuvant chemotherapy. Neoadjuvant chemotherapy, abbreviated NACT, is chemotherapy before the surgery. Typically, the only women who have chemotherapy before surgery are those who are poor surgical candidates for one reason or another. And the hope is that the chemotherapy will decrease the quantity of cancer so that the surgical procedure can be less extensive. It's a matter of making it possible for the woman to have a more minor surgical procedure. So the timing of chemotherapy just boils down to whether it's before or after the surgery, and if possible, it's afterward. Next is the route of chemotherapy. Route, or route, refers to how you receive your chemotherapy. There are three possibilities: oral, intravenous, or intraperitoneal. Oral chemotherapy means you take it by mouth, usually in the form of pills. Intravenous chemotherapy means that it is infused into your vein. And intraperitoneal chemotherapy means that it is instilled directly into your pelvic and abdominal cavity. So intraperitoneal chemotherapy is localized chemotherapy. Obviously, the oral intravenous routes are systemic. They send the chemotherapeutic drug all over your body to kill any cancer cells anywhere in your body. The intraperitoneal route, though, delivers the highest concentrations of the chemotherapeutic drug at the very site of the cancer. This does not necessarily make it better, and it is certainly the newest of the three routes. Oral and intravenous chemotherapy are much more common, and some women receive chemotherapy by more than one route. The last aspect of chemotherapy is the actual drugs. While different kinds of epithelial ovarian cancers respond to different kinds of chemotherapeutic drugs, the most common drugs are cisplatin and taxane. These two drugs constitute the standard of care for treatment of epithelial ovarian cancer. However, one of the most important things for you to understand about epithelial ovarian cancer is that cure is not what is meant by treatment. Of course, the hope is that treatment will result in cure, but in the vast majority of cases, treatment does not cure the disease. Because of this, there are always efforts to find novel therapies that could eventually be an improvement over current therapies. Some of these novel therapies include immunotherapies, antibody-based therapies, cancer vaccine therapies, targeted therapies, gene therapies, and hormonal therapies. It always comes back to the same thing. And unfortunately, cure is not what is meant by treatment of epithelial ovarian cancer. So that's the scoop on chemotherapy. It is a standard part of treatment, but does not routinely result in cure. In fact, actual cure of epithelial ovarian cancer is not the norm. And this brings us to clinical trials. Clinical trials are options for women who have exhausted all the conventional or standard options I've presented thus far. The goal of participation in a clinical trial is to determine if a different, unconventional treatment regimen produces better results than the standard regimens. This essentially amounts to trying experimental treatments. There are three categories of clinical trials. Phase 1 trials assess dosage. Phase 2 trials determine whether or not the medication is effective. Phase 3 trials compare the unconventional treatment to the standard treatments. Because the standard treatments are not meant to cure epithelial ovarian cancer, many women participate in clinical trials as a last resort. Clinical trials are plentiful, and so is participation in them by women with epithelial ovarian cancer. And if you've watched the units on other cancers, you know that this is the first time I've presented clinical trials as an option category. That shows you how much worse epithelial ovarian cancer is than any of the other cancers. The final category of treatment is palliative therapy. Now, this is a category that people tend to overlook. I mean, nobody likes to think about cancer being untreatable, but the cold hard fact is that epithelial ovarian cancer is a very difficult cancer to treat. It has a very high mortality rate. So it is quite common that there comes a point at which people turn to palliative therapy. Most people confuse the term palliative therapy with the term end-of-life care or hospice care. They are not the same. Palliative therapy can and should begin long before end-of-life care comes into play. Palliative therapy includes continuing to do everything possible to limit advancement of the cancer and avoid complications of the cancer. It entails continued medical intervention. In essence, it entails everything except active surgery or chemotherapy. And it is important because cure is not what is meant by treatment of epithelial ovarian cancer. So palliative therapy includes preventing recurrent and new cancers, continuing surveillance for spread of the original cancer or the recurrent cancer, intervention for complications from previous cancer treatments, and coordination between healthcare providers to bridge any gaps in care. Palliative therapy is something that all women with epithelial ovarian cancer deserve as soon as they receive the diagnosis. It is not something that is meant to replace treatment. Rather, it should accompany treatment. So there you have it, the treatment for epithelial ovarian cancer. So what is meant by treatment? Of course, as with all cancers, most treatment is dictated by stage. So let's designate the treatment for each stage on our staging chart. Generally speaking, surgery and chemotherapy is the standard treatment for all stages except stage 4. By stage 4, it is likely that the surgery is too extensive or the patient is too frail. Even epithelial ovarian cancer that is limited to the ovaries is treated with both surgery and chemotherapy. And with this particular cancer, it is actually better to overtreat than undertreat. And that's because it is such a difficult cancer to detect early, even when it's a recurrent cancer and you're looking for it and expecting it. Recurrence actually touches on the matter of prognosis. So I will stop here today, and as usual, the next video will pick up where this one left off with prognosis. Be sure to acknowledge that our discussion today focused only on epithelial ovarian cancer. You've learned that there are 63 different kinds of ovarian cancers, and epithelial ovarian cancer is just one of 3 categories of ovarian cancer. But it is the most common, it is the most deadly, and it is the most pertinent to postmenopausal women. There are all sorts of other treatments for some of the other kinds of ovarian cancer. So the summary for today is this. Standard treatment for epithelial ovarian cancer involves surgery first, which serves to label the cancer by grade and stage, as well as remove as much cancer as possible. And chemotherapy second, which serves to kill any remaining cancer cells. Or chemotherapy first, which serves to make the eventual surgery easier, and surgery second to remove as much cancer as possible. Or clinical trials, in which women try experimental treatments after failing standard treatments. Or palliative therapy, which entails everything other than surgery or chemotherapy, and serves to prevent cancer, detect cancer, or avoid complications from cancer. The standard treatment for all stages except stage 4 is both surgery and chemotherapy. And the chart is also your summary. You can find it at menopausetailor.me or via the link in the description box. While you're at menopausetailor.me, go ahead and schedule that consultation that you've been wanting and needing. I will give you the royal treatment in a consultation. So go ahead and subscribe to both my newsletter and my channel. The newsletter announces things like giveaways and discounts. And go ahead and follow me on Facebook, Instagram, Twitter, and TikTok. Bye, my students.